If we think about patient selection and HCC for TACE, of course, the target population are BCLC-B patients. You all know that we are treating more and more early stage patients like BCLC-A patients. And I think this is an interesting move. It's because of treatment stage migrations. It might be because we treat patients with, I would say, pre-transplant. In this regard, it's interesting to see that a recent presentation at ASCO GI with more than 500 patients demonstrated outstanding outcome with an overall survival in the range of 50 months. So I think it's a very important point that we have to go at the tumor board. We have to discuss BCLC-B patient, but we also have to discuss BCLC-A patient in some cases.
I think there are arguments in favor of both platforms. Lipiodol-based TACE, so the conventional concept, is relying on this fluid-like behavior of the lipidol, which is able to really penetrate deep into the tumor, and it causes also tumor staining, so that you basically can see where you administered your emulsion of lipiodol and your chemoembolic substance. And the other is the drug-eluting bead platform, which carries some advantages, in my opinion. For example, first of all, it's a little bit more standardized as compared to the conventional lipidol-based TACE platform. And you have a little bit a better toxicity profile. So patients usually tolerate drug-eluting bead TACE a little bit better than the conventional TACE, especially in extensive disease, multifocal disease, or relapse after previous treatments. But of course, there are advocates and arguments in favor of both platforms. So we will discuss this in depth during our webinar in May. Yeah, complications when it comes to chemoembolization in the liver are quite rare, especially complications which need further medical care or even interventions or surgical procedures are fortunately quite rare when we are performing this treatment. But anyhow, as you all know, if you have performed many chemoembolization procedures, you will see complications once and there in your lifetime. And we will have a very famous faculty in our webinar, and they are all presenting complications which they have seen in their medical career. And I hope that we can all learn from these complications, because if they occur, you need to decide how to proceed from that point on. And I think this is very helpful and a very meaningful teaching point during our webinar.
I will say that what we learned from the past, that there is no sense to combine TACE plus TKI inhibitor or VEGF inhibitors, and there have been a few studies out there which were all negatives. What is subject for research now, and it's only research today, it's combination with immunotherapy. And many major pharma are working on this topic. And today, BCLC-B patients are targeted. And we can think about the EMERALD-1 study that's compared TACE alone versus TACE in combination with durvalumab plus bevacizumab, or TACE in combination with durvalumab plus tremelimumab. Other company is running the CheckMate 74, which is again a 3-arm study comparing TACE alone versus TACE plus nivolumab and ipilimumab versus TACE plus nivolumab alone. And I think that we need to have those results. It might improve, enhance the overall survival of our patients. But we, as interventional radiologists, maybe we have to think about combination treatments for more advanced BCLC-C patients And we know that today atezo-bev is the treatment of choice, but maybe we should ask ourselves that priming tumor response with TACE before starting atezo-bev might be an option. To my knowledge, there is no ongoing trials, but maybe it is our role to think about and to try to open such trials.